speaker, Dr. S Ramesh, who is going to tell us about the future of total intravenous anesthesia in children. Dr. Ramesh.
Good morning, ladies and gentlemen. Nice to be here in the morning of a wonderful evening last night. And I'm giving a talk, TIVA, Are We Looking at the Future? This is actually, I'm sure this is Yamashita, Lakshmivas, and Ramesh in 2001 when the first ASPA was done in Singapore. And really a nice meeting with a small gathering, and now it's come to about 600 to 700 people now. The future of pediatric anesthesia is total intravenous anesthesia. That's a good article in 2002, but it doesn't reflect the truth, but as TIVA is only a part of good pediatric anesthesia. Because we are all clinicians, and we want to take care of the child, and the child should be all right, but I don't think we should stick to a particular part of technique, but you need a combination of that, which you will realize at the end of about 15 minutes of my lecture. As you know, TIVA anesthetic technique involving no inhalation, by definition, no inhalation agent, including volatiles and nitrous oxide, which is difficult for us to swallow that. The second, TIVA requires intravenous induction. As you see in that technique given by Ankat, I think we are all in favor of an inhalation induction, and then later on I put it is not exactly a TIVA. The third is vapor. If we can't live with it, can we live without it in anesthetic in children? I think that's a big question which will be answered after about 15 minutes. A lot of disclosures than many of my subject, because I am a poor mathematician and a poor pharmacologist. I do not understand pharmacokinetics and pharmacodynamics. I do not use TCI pump. We do not have any fentanyl in India. I feel I'm not worthy enough to give a talk in TIVA here, because Dr. Kira Mason has chaired a session of SIVA, World SIVA in 2007, and she's written a book on total intravenous anesthesia. She's in the audience. Dr. J. Lerman has done a lot of work on TCI and TIVA, where are we and where we are going, and he's in the audience. Dr. Manoj Karmakar, about 20 years ago, when I went, about 10, 12 years ago, when I went to Hong Kong, and that new hospital has no nitrous oxide in central supply and easier. And Charlie Cote in his book has written the chapter on TIVA and easier. And then why I'm here? That's because I am a good friend of Vrishali Pandey. All must be wondering why we are dating at the end of the night like this, but believe me, don't get heartened. And I found Pankaj Kundras, don't worry about it, okay? So what we are going to hear about 15 minutes is TIVA is nothing new to me, and TIVA old wine in new bottle video, which was, I took a video, I don't know whether Charlie Cote will know that. It was in Lausanne when the retirement party of Martin Zor and Isabella Murat, he showed a video, and I was taking the video of that, and the clip I'm going to show. It's a beautiful video, everyone should see that. The roadmap of TIVA, conceptual facts about TIVA, then clinical application, and concluding remarks. I promise you I'll finish in 15 minutes of time. TIVA old wine new bottle video. It's a very old video that also been taken from the screen, so the audio will be a little different, but it gives you all the information what you want for TIVA. That is in 1948 video, okay? All anesthetics, however administered, must pass in the blood to the brain. It is logical, therefore, to inject them directly into a vein. Nearly all the common anesthetics, including ether and chloroform, have been given in this way, but have been found unsuitable for various reasons.
Here is the apparatus you will need. Sterile 10 cubic centimeter syringes and 20 cubic centimeter syringes with eccentric nozzles. A wide-bore needle or cannula for mixing the solution. A hypodermic needle for the actual injection. ether or sterile water in a bowl for rinsing the syringes, sterile gauze swabs, a holder for the ampoules, ampoule files, an artificial airway, quarter-inch adhesive tape for fixing the syringe to the forearm, or this varies so greatly in their behavior under barbiturates that it's impossible to judge the dose in advance. Give each patient the same initial rapid injection of 3 cubic centimeters. Note the time and watch their reaction closely. With experience, you will then be able to form a very reliable estimate of their susceptibility. The patient will lose consciousness in about 30 seconds.
The breathing is monitored by the movement of this cotton verb. You see that? That's the only monitor which is available.
This will usually be followed by a period of apnea lasting 5 to 20 seconds, corresponding to the maximum effect of the pentothal. On this, mainly, you judge their reaction. With the effect of the pentothal wearing off, and with carbon dioxide accumulating, she starts to breathe again. Equilibrium is established with a higher level of alveolar carbon dioxide, and she won't again become apneic, except with much deeper anesthesia. The greatest care must be taken from the start to maintain an unobstructed airway. Most patients will breathe very comfortably if the head is turned to one side on the pillow. Support the chin if necessary. Don't use an artificial airway if you can avoid it, as it tends to stimulate laryngeal spasm. 3 minutes have passed, and the patient shows signs of waking up while the towels are applied. Inject another 1 to 2 cubic centimeters. And again see that the airway is clear. All is now ready. Again note the time and inject 2 to 4 cubic centimeters according to the reaction to the initial dose. This patient is having 3 cubic centimeters. Until you have gained sufficient experience, it's better to err on the side of caution. You can always inject more, but you can't withdraw what you've put in. At the moment of deepest anesthesia, 45 seconds later, the surgeon makes his incision.
That's why the old surgeons are very fast. They have to do it with 1 dose of thiopentone anatomy.
During the operation, further injections of 1 or 2 cubic centimeters are made as indicated, usually by a slight movement of the arm or leg, not often quite as marked as in this case.
So you understood that TIVA was not now, the TIVA was sometime 1948. There's no monitor, no BIS, and no oxygen, no nitrous oxide sitting by the side and giving a TIVA. Anatomy was done. At the now second to the roadmap of TIVA, there's impressive advances are made in TIVA, an alternative to an inhalational anesthetic. And advent of propofol made TIVA possible. And then propofol was made with chemophore, which is not a base to dissolve And thus, Dr. Glenn went into ICI after his anesthetic work in the evening. He worked in the in this department with the ICI and said propofol in a lipid macroemulsion is proved workable, and that made propofol workable. The second came a vaporizer for an IV anesthetic. I think that came as target control infusion. This is not exactly a vapor because a vaporizer depends upon the physics. By target control infusion depends upon the model prediction. It not exactly tell you what it is. There's a difference between that. Then there's computerization infusion system where exactly how much can be given, what will be the target, so that target infusion commercialization talks in this shape because the computerization of the pump came into the market. So the first pump is deprifusor by Grasby for the propofol with a chip in it to find exactly how much to be given. This is a schematic diagram of TCI, and it's a little complicated ones because how much to be given pharmacokinetics, and this has many contributors, many vendors, and there are many names given to it, like many things. We are all as an anesthetist, we are in MAC. Everyone, when you come the PG, come to the first class, they'll ask you what is MAC, and we are into the MAC. And MAC is big and is one of the finest concepts in anesthesia. Though there are a lot of variations, controversies have come into the market, and easy, if you put this one and you find that CO is given and you know easy to control the MAC, and we are used to controlling the vaporizer. But we want a MAC for TIVA, which is not exactly we want, and we are really coming into the MAC to the TIVA, and that is slowly coming. I'll let you know one thing. This is what it is, the MAC which is here. When you give a fentanyl or a narcotics, MAC comes down with the inhalation agent. And we use with the TIVA, the similar concept is plasma concentration or EZ50, that is the effective concentration comes by 50%, but giving a narcotic, that is what it is, similar to MAC, but little difficult to understand the concept like what it is. Then came the targets, and the gadgets and the gizmos come in different models. I couldn't understand, even outside there is one which is giving you, is an Alaris pump, which is this is a Grasby pump, this is a Thermo, and Vibron has got different type of TCI pumps in different concentrations and things like that. Then when he said, when you measure the expired concentration of sevoflurane and isoflurane, if you can measure the expired concentration of propofol, that's what we want how much to be in. That lot of research has gone into it to measure the expired concentration of propofol with the help of combining with this molecule and finding out with this one, with the Lonistab monitor, we can find out. But it's not very practical. Because we want, as soon as you cut down, we want immediate concentration. Whereas in this one, it takes delayed time before you induce. Now it takes about 30 minutes to exactly know what propofol. And if you cut down, it takes another 30 minutes. So I think soon it might come so that you can faster one. So expired concentration propofol will be a good idea to give the TIVA to be done. And now the latest thing is got a GE has got a navigator system which everything is included into it. You can control it, you can control the TIVA, how much to be given, you can get the feedback with the base and said exactly no. Whereas Drager has got a smart pilot system where, so both of us are competing. It's similar to, it's a computerized smart system where both can be included in that. And TIVA TrainX has come in our apps. We are all in the apps world where the applications or the apps are there in TIVA where you can find out the concentration. We can download that. It comes mainly in the Apple, but you could also get it to the Android so that you can exactly know what concentration you can keep it. And TIVA is a good one with the, you can even now if you have TIVA TrainX, you can get all the details. And I want to tell, I'm proud of this in India. I got what is called the closed loop anesthesia delivery system, which was invented, or a beautiful innovation by one of my colleague, Govardhan Nath Puri, who is my colleague and in 1985. He is now head of the Department of Postgraduate Institute in Chandigarh, developed a beautiful system. And he has published many papers and he awarded many awards within India and outside the world. I'm proud to say I'm his good friend, and you can do the clad and I see what exactly to do by the pouring. Having done that, TIVA is not old, TIVA is not new, TIVA is old, and it has been very well developed even from 1948. Then I found what is the roadmap of TIVA, which is coming into the gadgets and whatever there is. Now I am coming into the certain conceptual facts about TIVA. It took almost 6 months to understand this, but I'll give you in 3 minutes of my time, because I'm very bad in reading, but somehow with all the articles I could read and I can understand, and I can transfer in about maybe in 3 minutes of time. This is a beautiful picture. I took it from Egan in Journal of Clinical Anesthesia, which really you can understand the whole what TIVA means. Because you know this one, the first one is, the top one is inhalational and lower one is intravenous. This is the one. This is inhalational. Is access is very easy. Okay. The access is very easy because you are going into the lung and it equilibrates with the blood vessel, and then once the equilibration comes, the concentration is a MAC and the child goes to sleep. And then there's a vaporizer. We can just put 1%, 2%, easy to know that. And then when you say that this is the pharmacokinetic and pharmacodynamics, in case of inhalation are very good, because you can exactly tell you 1 MAC, 1.5 MAC, 1.2 MAC. What happens inhalational? Inhalational, you see, give into the vein, it disappears, it is a continuous process, you don't need equilibrations. We don't know exactly how much to deliver. And you can see this fellow is not smiling because you don't know what is the target concentration you are achieving. Whereas in inhalational, you know what is the MAC, but if you can put a smile on this fellow, I think that is the aim of TIVA, because you can exactly measure the target concentration. That is the end of the TIVA, which you can do that. And this article is given by Lerman, that infusion pumps are setting up is very, very difficult. As an old man, I can't do it. I always tell the resident, please set the infusion pump. They are happy to do it. And we are not familiar. Every pump comes in different knobs. We don't know everything. And TCI pumps are very expensive. We have to exert concentrations. And feedback of this correlation depth is not really very okay with that. And we are all thinking of propofol pain and propofol infusion syndrome. So TIVA can be manually controlled infusion, or it can be a target control infusion, and target control infusion should be a closed loop with abyss feedback, or open loop with a target concentration. Manual control infusion was propofol was started by Roberts, and Roberts said initially give 1 milligram per kg as a bolus, then 10 milligram per kg per hour for 10 minutes, to 8 milligram per kg to 10 minutes, then 6 milligram per kg hour. This was in adults, but they found that the target concentration of 3 microgram per ml is not achieved by this in children because the clearance rate is high. So metformin and pediatric anesthesia changed to 15, 13, 11 and 12, 10, and it was okay. Then they thought a little more, and Sewer modified into 12, 9 and 6. What we do is that we give propofol 1% lipido, induce it 2 to 5 milligram per kg, then 10 milligram per kg per hour for 10 to 20 minutes, then reduce it. We add dexmedetomidine or ketamine depending upon what you need for that particular procedures. The target control infusion, what is the target you want to achieve? The best target to achieve is the effective target, but it's very difficult to know. So we can achieve either blood target or an effective site. And there are so many models, Marsh model, Kataria model, Shuttle and Pete-Fusar. Pete-Fusar is usually a practical model for everyone. And this is one, if you can understand, I understood after a long time, then you given as a bolus, it goes in the blood vessel. That is the central compartment. After that, the drugs goes to 2 compartments. One is a blood-rich compartment, other the blood-less compartment. So the blood-less compartment is huge, like a muscles, which is stored more air. Whereas blood supply more is with the kidney, heart, and the brain, so it's a smaller compartment. So what you want, I understood with this is that the propofol you are thinking is short-acting. It is not really a short-acting. I can tell you that because it goes and being in the muscle and it comes back. It takes even about 8 to 12 hours before it comes down. So the second concept you must understand is context sensitivity of time. The time 50% fall in pharmacology from steady state after state of the given duration. After you stop the propofol, and the time to come to 50% is the context sensitivity of time. This is much more in children, almost double in children than in the adults. What is the clinical significance? You know, by clinically, it is high dose requirement. You need at least 6 to 7 milligram per kilo as a bolus, and because of depot effect, it took a long time to come back and slow recovery. So if you want to avoid all these things, use propofol sparing measures, taper infusion long time before you want to end it. You taper it, then I switch over to inhalation at the end, especially in scoliosis surgeries. So if you want to use this propofol on injection, less percentage pre-inject analgesia, mixed lugnakine or something like that. And this is a propofol-induced syndrome. Is used 2% propofol, so your lipid infusion will be, lipid load will be less. Lipido formulations like medium child formulations are much better. There are new formulations for propofol, cyclohexidine or fast propofol, which is water soluble, is coming into the research. And Andrew Wolf, who done a lot of work in Bristol of the propofol infusion syndrome death, and when I met him in Australia, he told me the dosages should not exceed more than 8 milligram per kg per hour. Duration should not be more than 48 hours, and there is any systemic infection, do not use propofol. These are 3 things I follow when you want to use propofol. So there are sparing methods. You want to use propofol sparing, like give regional analgesia. You read every day yesterday, give some opioids, ketamine and dexmedetomidine, monitor depth of the anesthesia. To BIS or not to BIS is a big question, and which index, probably 40 to 50 is a fairly a good method, but adult definitely useful, but more than 1 year perhaps it may be useful, less than 1 year it's not very useful. And next is about awareness. If you want anything about awareness, this is actually NAP5, and you can tell you exactly the awareness to TIVA, and these are use opioid, BIS monitoring, and avoid paralysis. If you only have one line, if you want to give, you got an octopus type of thing, you have the one intravenous line, one propofol, next is a fentanyl, next you can give the fluids with a single IV line. So clinical applications of TIVA in children, I used initially without anything because one of the residents became pregnant, we don't have a scavenging system, I thought TIVA is the best. And if you want to use the neuromonitoring in like scoliosis, TIVA is the best. And if you want to use for MH, yesterday we had a panel discussion, and then TIVA is the best for MH. And for airway surgery, I find that really when you don't want anything, then TIVA is the best because you can do the TIVA surgery without any inhalational agent. And TIVA for MRI, I'm using for last 15 years. So I just want to conclude certain remarks which are very, very useful to us. If you want intravenous access, it's a difficult access. It's a big subject by unknown. It causes apnea, and it's a complex dosing. We don't know each children differently. Whereas inhalational is easy mass induction. It's a spontaneously you can use it, and it's a simple dosing. You can see it, 1%, 2%. You saw what Ankit was doing in the morning. So to conclude with the last slide, you see, there's a beautiful article by Dr. Lehman and Martin Zord, a beautiful article, and he said that you should complement each other. There's nothing like TIVA, nothing like inhalation, and please complement each other as a pediatric anesthetist. Do it so that you can good this one. So I want the TIVA, I'll convert that into PIVA. It is not total intravenous anesthesia, it is a partial intravenous anesthesia, so that it can give a good care for the children than to stick on to one concluding as a TIVA. So I think these are many articles I read. Believe me, I read all these articles. So if you want anybody to send these articles, please say, I know in India, very difficult to get the pediatric anesthesia articles. It takes a lot of time. I wrote to many people and got this. If anybody interested in TIVA, I can tell you, I have not written anything on the notes, but I can send you all the articles in this email. Thank you very much.